Hello and welcome to our first in a series of lectures regarding aortic regurgitation. With this particular lecture here, we're going to move through the various views that we use to assess aortic regurgitation in both transthoracic and transesophageal echo. Then we'll explore the clinical presentations and symptoms they may present with when they have significant aortic regurgitation. We'll address some common secondary findings associated with this pathology. And then we'll look into valvular degeneration and how this can actually lead to aortic regurgitation. Aortic regurgitation may arise from leaflet destruction, loss of support structures, annular dilatation, or inability to make good leaflet coaptation. Hypertension may play an effect. Basically, higher the blood pressure, the more significant the jet. The duration of flow and the length of the jet are also increased with hypertension. It often looks like someone actually squirting a water pistol. The blood flow moves very significantly quickly into the ventricle. Most common aortic regurgitation is mild or trivial and arises from the center of the valve where all three leaflets coapt. The direction of the jet is also normally central. This can be the result of sclerosis, creating a rough edge and limiting the actual ability for the leaflets to coapt. Aortic root dilatation effectively pulls the leaflets apart so they do not coapt well. Imagine a door and its frame. If the frame gets bigger but the door stays the same size, it effectively can't close and stop the flow moving. So starting with the standard view that we'll work with is the parasternal long axis. Typically the anterior leaflet is going to be the right coronary cusp. The posterior is usually the non-coronary cusp. The point of coaptation to be about the middle of the aortic root level. The sonographer also needs to be able to sweep through the image, tilting anterior and posteriorly to see all three leaflets, and then again with colour. This identifies where the direction and origin of the actual aortic regurgitation. And here we have an example. A colour box has been placed over the aortic valve, and we can see this blue flow in diastole of blood moving backwards, basically moving away from the probe and getting the blue colours. In the parasternal short axis window, the leaflets make a Y shape when the leaflets are closed, and again the coaptation point should be relatively centered when we see it. The sonographer needs to be able to pan through the valve again with colour, tilting the probe superiorly and inferiorly, thus moving through up to the ST junction level and then down into the LVOT. Again, this obtains the origin and the direction of jets, which is important for the analysis of severity of it. And here we have an example of a parasternal short axis window where we can see blue blood moving down through the aortic valve backward into the ventricle. In the apical 5-chamber view, we typically will see the right and left coronary leaflets. And it's important that the sonographer opens up the aorta, the aortic valve, the left ventricular outflow tract, and the left ventricle. And then colour is applied along the entire length to demonstrate whether we have trivial or significant aortic regurgitation, seeing its origin and its direction moving into the ventricle. And here we have a good example. So 5-chamber view, so we've got the aorta down here, aortic valve and left ventricle, and we can see a significant red flow of aortic regurgitation moving into the chamber. Sometimes this can actually be complicated because in diastole we have filling of the ventricles at the same time from the left atrium into the left ventricle, and the flows can commingle. So it's up to the sonographer to try and move away and only obtain the flow of interest. In the apical long axis view, it's basically the same as we've noted before as our parasternal long axis view, but just rotated 90 degrees so the left ventricle is vertical in the image. Again, the aim is to open up the aortic valve and the ascending aorta along with the LVOT and the LV, and applying colour there so we again can see origin and direction of flow if we have a regurgitant jet. And here we have an example looking at colour over a long axis view. Now those of you who are actually astute will note that we wouldn't actually see aortic regurgitation in this fixed frame because we're actually looking at systole. We can see mitral regurgitation, and we know that they alternate between the two, mitral regurgitation in systole, aortic regurgitation in diastole. The subcostal view may also be used to assess for aortic regurgitation, particularly in the short axis. And this looks the same as the parasternal short axis window, but again with the view rotated 90 degrees. This view is particularly useful when there is significant attenuation or artifacts present anterior to the aortic valve, such as if you have a prosthetic valve with significant aortic calcification. By effectively coming side on, the ability to image the valve may be improved. So in our image here, we can see a typical short axis view from subcostal, so we can actually see the liver and the IVC coming through. And then what we've done is we just simply zoomed up on the aortic valve and applied the colour, and we can see the flow as it moves through the valve. Transesophageal work is advantageous when assessing for aortic regurgitation, as we use high frequencies that allow for greater spatial resolution. The important thing to note is it's not always useful when viewing anteriorly with prosthetic valves. Artifacts are often cast over the region of interest. And this may be important if we have dehiscence or if we have paravalvular regurgitation. Another thing to note with transesophageal work is colour looks less impressive on toe, as colour pixels are smaller, frame rates are generally higher, and optimal flow alignment may not be attainable. And here we have a long axis view of the aortic valve, and we can see the red colour of blood moving through the valve into the ventricle, which is demonstrated down here. The short axis view is basically a mirror image of the parasternal short axis view from transverse work, but with the right ventricular outflow tract demonstrated towards the bottom of the image, so basically a mirror image. The operator will pull back the probe slightly to pan through with colour, and note the probe face orientation on the screen. So in our long axis view, we have an angle of 146, and our short axis view will have an angle of 35, as we see on the next window. So what the operator is actually doing is an electronic control to actually steer the probe, and there we move from a long axis to a short axis. And here we've got colour flow on the valve. Aortic regurgitation and its findings. Basically, it sounds like a soft rumbling and high-pitched decrescendo murmur starting from early diastole. It's best heard at the third intercostal space, and usually S1 and S2 are normal. An Austin Flint may be heard if the jet is significant, and if more so if it's posteriorly directed onto the anterior leaflet of the mitral valve. This creates a low-pitched rumbling mid-diastole murmur. Typically, patients will present with shortness of breath, orthopnea, chest pain which may increase with exertion, palpitations, fatigue, dizziness, syncope, swelling of ankles. In the instances where we have significant aortic regurgitation, we may also observe a wide pulse pressure, a vast difference between the systolic and diastolic readings. Secondary findings that we expect to see in the echo would include left atrial dilatation, left ventricular dilatation, increased pulmonary pressures, RV dilatation, right ventricular hypertrophy, right ventricular dysfunction, raised JVP, or peripheral edema. In summary, we typically use the same views for assessing the aortic valve and regurgitation as those with stenotic lesions, and that's why we haven't spent too much time moving through the images there. Panning through the valve is particularly important. It is necessary to see the origin and the direction of regurgitation. Patient presents with typical clinical findings, which sonographer should be able to identify, and then using that information, alter what would be the normal standard scan and apply advanced scanning techniques to assess for aortic regurgitation. There are secondary effects that we see with aortic regurgitation, which means the sonographer must extend the scan, as we just mentioned, so the study is more than just the valve itself.